Good evening everyone, how are you? Hope you are doing good. Today I am going to discuss about one of the important anti-diabetic agent, that is thiazolidinediones. Let's go into the topic. Thiazolidinediones are the ligands for the PPAR gamma receptor. PPAR gamma receptor is a nuclear hormone receptor. It has two isoforms. It is involved in the regulation of the genes related to glucose as well as lipid metabolism. We have only one thiazolidinedione which is currently available to treat the patients with type 2 diabetes mellitus, that is pioglitazone. Rosiglitazone and troglodyazone were removed from the market. Rosiglitazone is removed because of cardiotoxicity and troglodyazone was removed because of hepatotoxicity. Now coming into the mechanism of action, thiazolidinediones activate PPAR gamma receptors. Where it is present, it is expressed primarily in the adipose tissue. It also has lesser expression in cardiac, skeletal, smooth muscle cells, islet B cells, macrophages, and vascular endothelial cells. Like thiazolidinediones, we also have endogenous ligands for PPAR gamma receptors. So what are they? Which includes small lipophilic molecules like oxidized linoleic acid, arachidonic acid, and prostaglandin metabolite 15D PGJ2. So pioglitazone is a ligand. It is binding to PPAR gamma receptor. After binding to PPAR gamma, what will it do? It will form heterodimer formation with retinoid X receptor. After that, it will have interaction with PPAR response elements on specific genes. So what is the primary response to PPAR gamma activation? Is nothing but adipocyte differentiation. PPAR gamma activity, it also promotes uptake of circulating fatty acids into the fat cells, shifts the lipid stores from extra adipose tissue to the adipose tissue. So what is the consequence of the cellular response to PPAR gamma activation? Is increased tissue sensitivity to the insulin. So pioglitazone is an insulin sensitizer and increase insulin mediated glucose uptake by 30 to 50% in patients with type 2 diabetes mellitus. Although adipose tissue seems to be the primary target for PPAR gamma agonist, both the clinical and preclinical models, they support the role for the skeletal muscle to be the major site for insulin-mediated glucose dispersal in the response to thiazolidinediones. So in addition to promoting glucose uptake into muscle and adipose tissue, like metformin, thiazolidinediones reduces the hepatic glucose production and increase hepatic glucose uptake. So it is not clear whether thiazolidinedione induced improvement of insulin resistance is due to the direct effects on key target tissues like skeletal muscles and liver, or due to the indirect effects mediated by the secreted products of adipocytes like adiponectin, or it is because of a combination of these direct and indirect effects. Thiazolidinediones also affect the lipid metabolism. So treatment with pioglitazone, it reduces the plasma levels of fatty acids by increasing its clearance and reducing lipolysis. These drugs also cause a shift of triglyceride stores from non-adipose to adipose tissues and from visceral to subcutaneous fat depots. So pioglitazone reduces the plasma triglycerides level by 10 to 15%, raises the HDL cholesterol levels, and also increases the LDL cholesterol levels also. So dose of pioglitazone is, the starting dose is 15 to 30 mg. It can be increased up to maximum of 45 mg daily. So it is absorbed within 2 to 3 hours and viability is unaffected by food. So where it is metabolized, thiazolidinediones are metabolized by the liver. So it can be administered to patients with renal insufficiency, but it should never be used in patients if there is an active hepatic disease. Rifampicin is an enzyme inducer, so it induces the hepatic cytochromes and it causes a significant decrease in the plasma concentration of pioglitazone. Gemfibrozil is a fibrates which is indicated for hyperlipidemia. It can impede the metabolism of thiazolidinediones. It can increase the plasma levels of pioglitazone by about 2 folds. So if you are combining gemfibrozil along with pioglitazone, the dose reduction is registered with this combination. The onset of action of thiazolidinedione is relatively slow, so the maximal effects on glucose homeostasis develops gradually over the course of 1 to 3 months. So what are the therapeutic uses of thiazolidinediones? Thiazolidinediones enhances the insulin action on the liver, adipose tissue, skeletal muscle. It confers the improvement in the glycemic control and in patients with type 2 diabetes mellitus. It causes average reduction in HbA1c of 0.5 to 1.4%. These thiazolidinediones require the presence of insulin for pharmacologic activity. That's why it is not used to treat type 1 diabetes where there is no insulin is present. So pioglitazone is effective as monotherapy and also as an additive therapy to metformin, sulfonylureas along with insulin also. So in addition, pioglitazone is marketed in fixed combination with DPP-4 inhibitors like allogliptin also. So what are the adverse effects of pioglitazone? The most common adverse effects thiazolidinediones are weight gain and edema. The thiazolidinediones, it causes an increase in body adiposity. It can increase in the average body weight gain of 2 to 4 kg over the first year of the treatment. By adding insulin, it will double the incidence of edema and amount of weight gain compared with either drug alone. So macular edema has also been reported in patients using pioglitazone. So this is not a consistent finding in the recent clinical trials. So as with other side effects of thiazolidinediones, fluid retention is dose related. The use of thiazolidinediones is associated with the mild reduction of hematocrit. Hematocrit is volume of red blood cells is reduced if you are using thiazolidinediones. It may be an effect of fluid retention also. It can also be a primary effect on hematopoiesis also. But primary effect on hematopoiesis has not been excluded. Exposure to the drugs over several years in clinical trials, it has been associated with an increased incidence of heart failure up to 2-folds. So this heart failure has been attributed to the effect of drugs to cause plasma volume expansion in patients with type 2 diabetes, particularly those who have an increased risk for heart failure. But that does not appear to be an acute effect of pioglitazone to reduce myocardial contractility or ejection fraction. The use of thiazolidinediones in diabetic patients without a history of heart failure or with compensated heart failure can be initiated. But we have to monitor the signs and symptoms of congestive heart failure is very, very important, especially when it is combined with insulin. Thiazolidinediones should not be used in patients with moderate to severe heart failure, and more recent evidence supports either mild beneficial effects of pioglitazone on overall cardiovascular events or a neutral impact. So in a trial of non-diabetic individuals who have insulin resistance and a recent history of ischemic stroke or transient ischemic attacks, this pioglitazone reduced the risk of subsequent stroke or myocardial infarction and diabetes. This treatment with thiazolidinediones has been associated with a consistent increased risk of bone fractures in women, and with some studies also showing effects on in men also. Therefore, the presence of osteoporosis and other risk factors for fracture should be considered before starting thiazolidinediones. Pioglitazone is associated with the lowering of transaminases, which is probably reflective of reduction in hepatic steatosis. As I told you, it is metabolized by the liver, so it also has some adverse effects on liver. So thiazolidinediones should be withheld from the patients with clinically apparent liver disease, and liver function should be monitored intermittently during the treatment with. So thank you so much for your kind attention, and share my lectures to your friends.